My name is Camille Wellard, and it's my privilege and honor to be the moderator for today's panel. Before we begin, I'd like to thank my fellow program committee members, Victoria, Trish Godey, Nate Green, and Chase. In the back there, he's helped us with the communication for the event, and all of them have been instrumental in helping with this panel today. The format for the panel is an exchange of ideas and hopefully an interactive discussion. We'd like to hear from all of you and hear what you're interested in discussing today. There's a little bit of a hum. Is that better? Okay. I'll kick it off with a few questions while you guys are thinking of some ideas, but when you're called on for a question, please raise your hand and we'll ask you to stand and give your name and what role you have in your organization, and then ask your question. So without further ado, I'll dive in. First, I'd like to introduce our wonderful panel. We have Donna Milavetz. She's the CEO and Chief Medical Officer of On-Site Care Clinics. We've got Diane Rindlisbacher, the Chief Nursing Information Officer for Intermountain Healthcare. We've got Teresa Rivera. She's the President and CEO of the Utah Health Information Network. And we've got JaeLynn Williams, President and General Manager for 3M Information Systems. So to start the conversation, we'd like to start out with a common definition for the panel and for the audience of connected care. Connected health is an approach to healthcare delivery that leverages the systematic application of healthcare information technology to facilitate the accessing and sharing of information, as well as to allow subsequent analysis of health data across healthcare systems. But connected health goes beyond the management of patients' clinical data to encourage communication and collaboration among all the various stakeholders involved in patients' health. Connected health is achieved with a range of information and collaborative technologies, electronic medical records, and other clinical applications, data repositories, and analytic tools, connected biomedical devices, and telehealth collaboration technologies, all enabling connected health. Most importantly, those solutions must rest on a foundation of technology and data standards and security that ensures the confidentiality of personal health information. So given this definition, I'd like to turn this over to our panelists and ask how their organizations connect to this definition. And I'd like to start with JaeLynn.
All right, thank you. So when we think about connected care, I think where we go to as an organization and our thought process is that that's a very comprehensive definition. But at the end of the day, what we're trying to do with data and with technology is to actually make real-time electronic communication between a patient and their healthcare provider happen. And so when we think about healthcare really can be dissolved down to it's the interaction that you and I have with our physician. So we think about how do we apply technology, what do we do with data? It's really about, are we fostering that interaction, and are we taking away all of the noise and all of the distractions that are lower value? Because when we're in those situations, that's what we want. We want face-to-face communication with our physician, and we want our physician focused on our care and not so much maybe on what they have to enter into their EMR or other things that they have to do. So as an organization, we've really focused a lot on trying to facilitate that focus and the patient to physician information that will make that happen. So that comes down to things like, how do we measure what's important, which is outcomes, and how do we basically put to the side things that maybe are more distracting or process steps and things like that might take valuable physician time away from really driving an outcome that's most desirable for that patient. And then we also really focus a lot on incentives drive our behaviors. And so as an organization, we work closely with a lot of the states and with the federal government to really help implement payment systems that drive towards quality at lower cost. And some of those things that we need to be connected to better health we need better incentives, and we need better payment that really does support things. We need modernization in Medicare that supports telehealth and some of these things that are slow to adoption because the incentives are not aligned. So that's our view of connected care at 3M.
Let's just go down the line. We'll go next to Teresa.
At UHIN, we are the state designated health information exchange. And so what we're trying to work on is the ability for physicians to share data securely when they're treating a patient so that they have all the data they need to treat that patient. As a patient, I will tell you, I am not in one healthcare system. My physician is an independent physician, but I utilize the services of Intermountain. And so that data needs to flow back and forth with my physician, so my physician has the most information to be able to accurately and with quality treat me as a patient. And what we find is even in the largest healthcare systems in Utah, 20% of the patients are leaving that system for other care. It could be something as simple as emergency care, where you are in another town where you're not able to get to your physician. Or it could be specialty care, where you have the recommendation from your friend, your family, to go to this particular specialty clinic for care. But all that care needs to be shared. And what we believe at UHIN is that data needs to follow the patient on where the patient goes. So very much what JaeLynn said, we want that data to flow with the patient for their care. We actually have an acronym where we call it Patient-Centered Data Home. And what we want to do is make sure that that data is always with that patient's home, their primary care physician, for the best care and the best quality. Now, one of the outcomes is exactly what JaeLynn said, is you happen to have data that you can do great things with. Can you imagine how wonderful it would be to the primary care to understand out of his patient's population which of his diabetics need more care? Which ones just went to the ER and are out of the range for their diabetic care? Which ones just went to the ER with an acute asthma attack that they should be following up on? That population health in the primary care is another opportunity once we can pull this data and be able to share that data.
Thank you. Let's go to Diane.
I'm glad to be here today and would have to say that I really represent all of my colleagues at Intermountain Healthcare who really are focusing on what we would term connected care, we would term connected health. As I think about, after 40 years, Intermountain changing our mission to helping people live the healthiest lives possible. And in the context of connected care, really think about this as that patient, that individual who is seeking answers about their health. And if you think about this, most of the time that I, as an individual, or my mom and dad, or my nieces and nephews, or my friends spend thinking about their health, it's not when they're necessarily in a doctor's office or in a hospital. So as we begin to think about connected health at Intermountain, our focus really is on that individual's experience in the manner and the mode that they need, that's easy to use, that provides the information at the time they're seeking it. Now, if we're going in for a well child visit, taking a child in, or an annual physical, or if we have a chronic condition, our interactions with the traditional institutions of healthcare delivery, which is a provider's office or a hospital, home care, hospice, et cetera. In the past, we've envisioned that and the sharing of data in those bricks and mortar kinds of locations. But at Intermountain Healthcare, we were really looking more broadly and trying to focus our efforts on how do I prepare if I'm going to interact with a provider. So what tools can we use, what tools and technologies that are easy to use that we can put into an individual's hands as they come to interact with us? What can we do as care providers and a care team in ensuring that we understand what are that person's goals? What are their family's goals? And one of the areas we'll focus on in 2016 is an integrated patient-centered plan of care across venues, whether it's home care or select health, and the insurance arm, or a provider's office, or a hospital. We need to really look at this in a different manner, but the focus really has to be on the individuals and using technologies as an enabler to help people engage in their health. And that may mean, how do I engage using a Fitbit and share information so that maybe I'm trying to lose a few pounds or improve my blood pressure. Most of that work is not done in the typical settings that we traditionally have looked at from a healthcare perspective. And our vision is totally focused on the health of the individual and their interactions when they need to have interactions with us as a healthcare organization.
Thank you. Let's go to Donna.
Good afternoon. It's really a pleasure to be here. So I'm going to wear the doctor hat, speaking as the internist of the group, and sort of the dual hat of running primary care clinics, so looking at it from the patient side as well as from the clinician side. And kind of echoing the remainder of the panel here, it's from a physician perspective is that we need the tools necessary to provide the needed care and to help manage your health in a more integrated fashion. And if there is a specialist that I'm sending you to, whether it's in the system or outside of the system, it's getting back those referral notes or knowing what laboratory testing or imaging studies that have been done so that I can make the best clinical decisions on your healthcare and then to interface with you on how to best manage your care, because it really is a shared decision-making process there. I think the idea of closing gaps in cares, and I solidly sit in the employer-based space, so commercial market rather than Medicare or Medicaid, but think about the employer-based groups. They can change insurance every year, right? They can skip from Blue Cross to Select Health to United Healthcare, and they may have gotten their colonoscopy 2 years ago, but if they changed insurance carriers, then how does that patient or even that provider know when that happened? I can say that we can get a space mission to a probe to Mars, but I can't get stuff from the University of Utah in terms of data integration across town. And it's funny, but in reality, it's actually true. So redundancy of testings or retesting because I didn't know when your last colonoscopy was, or immunizations. When was your last tetanus shot? Does everyone know when their last tetanus shot was? Okay, I've got about a third, maybe a fourth of the population that does, but we have this great state repository called HIMSS that we should be inputting data into so that we can extract data from. Because nobody carries those little yellow cards anymore. So again, it's redundancy of services, putting patients at risk for necessarily doing sort of additional testing as well as procedures that aren't necessary. That sort of deals with the cost side, but also adverse outcomes. Medical errors. I can't tell you how many times people have said to me, I take that little pink pill. Okay, well, what is that little pink pill and what's the strength of that pink pill? So using smart technology to be able to say, okay, this is what actually the pink pills look like, which one is yours, and can we back into that information? And when I electronically now prescribe to my pharmacies my prescriptions for my patients rather than my chicken scratches, is that a 5 or is that a 7? So dealing with medical errors I think is really important from the clinician standpoint. Allergies. Allergies happen all the time again. That if I don't know what your allergies are because I've never seen you before, or you had an allergic reaction to a medication that somebody else prescribed to you that you forgot to tell me about, that's really important information for me to have when I'm prescribing drugs for you. And then again, sort of moving on that smart technology, I would love to have a smart technology for my diabetics to download their finger sticks right into my EMR so I can manage them better. And then turning that template around to them to be able to say, well, this is what your blood sugars have been looking like. So what happened on this date? Did you go out to dinner, or was there a party, or what was the birthday cake involved? So again, so using that information to, again, push it back to the patient and say, how do we better manage your care? So from a clinical standpoint, I think integrated care and coordination of care is fundamental to the practice of medicine in 2016. And figuring out the ways with the plethora of different electronic health systems that are out there to create those cross links, I think, is the challenge that is in front of all of us today, to better manage care, to decrease cost, and most importantly, to take the best care of the patients that we can.
Great, thank you. So I'd like to ask the audience a question. How many here are involved, given this description of connected care and our panelists' participation in that, how many here are involved in connected care at some level in the organization? Raise of hands. Quite a few. So I'd like to turn it over to the audience for a question. Anybody here have any questions they'd like to ask the panelists? Stand up.
Hi, I'm Bruce Fryer. I've been dealing with post-acute care management, especially, well, so here's what I see, a transition. Right now, healthcare is basically institutionalized, and that group provides it. But with the ACA and the high deductibles, a lot more care management is now shifting to the patients and the patients' families. Okay? And I actually had an incident this year, ski injury, left shoulder, bad pole plant. Anybody had that problem? So I went for my very first MRI, and I'm up in Park City. So the only place I could really go was IHC because their PAC system wouldn't talk to anybody else. And then I found out that so IHC's cost was $1,100 for an MRI, but if I went to a freestanding, I would have paid $400. Because it was high deductible. Guess who ended up eating the $600? So I'm putting this in context is what I'm seeing, and I was going to ask the panels. I see a huge shift because of the cost structure and all that going over to the patients, but not only the patients, but also the patients' advocates. Anybody here have a mom have a hip replacement or something like that? Okay. And so in the case did the doctor coordinate all the care management, or did you do it? Okay, so this is what I see going on. So I guess so Teresa gets it as soon as I see patient-centered data home, but I'd be curious if the rest of the panel sees this shift going for actually the patients and the patient's family members actually being the center of the care, and therefore the implications to us is that we have to make sure that we just don't give lip service to the patient, but they're actually are at the center, and they make the decisions, and they do the care coordination. These are my observations. I just want to see if Joel hears.
In order to do that, one of the things that you have to do is provide the transparency of what the best care is. And that's a combination of making sure that there's reliable information from a trusted source, and that you then allow individuals and their families to make a choice, which means that we have to provide transparency in cost, in treatment models, and care process models, so that I as an individual can decide what it is that I'm trying to personally achieve, how much money am I willing to spend from a high deductible care plan perspective, and what outcome am I personally trying to achieve. And that's where this becomes transformative in the way that
Cash costs for all your procedures?
we will be publishing transparent costs on on what this means so that people can make choices about their health.
Can I add on that? The All-Payer Claims Database that you're all aware of, that payers are required to provide data to, it's trying to get to that transparency as well. And they've done a study on maternity care, limited, but they're working towards that transparency. And I think health systems and payers themselves are trying to get that to that transparency of cost. But I want to emphasize something that Diane said. You just don't go to the cheapest place. You need to understand the quality. And unfortunately, to date, we've measured quality with HEDIS reports on claims data. Claims data is not enough. I mean, you can tell I've had my A1C on a regular basis. You can't tell if I'm in control. And so clearly you need to get to the clinical data, and it's the marrying of those pieces, two pieces of data, to understand cost and quality, so really that patient can make a informed decision of where they want care.
Yeah, outcomes data is really important as a quality measure.
Right, so kind of to take off of where Teresa left, so we at 3M have been involved in running several of the APCDs around the country. And one of the first steps for that is having consistent models to risk adjust your population, so that, to your point, you're really comparing an apples to apples population, and then from there measuring the outcome of the patient and not the process measures. So really a kind of a watch cry from our philosophy is that what you care about when you go to get care is, was I better when I left? You don't really care so much about some of the decisions that are made in the process of care. You trust your caregiver to make those decisions for you. So there certainly are best practices. You know, did you get an aspirin? Did you have your bed elevated? Those are all important types of care, but we're spending a lot of time measuring process measures. It doesn't mean that you survived or you came out better on the other side. So what we really want to do is have a standard way that we risk adjust populations and that we measure outcomes. So we've been doing that and looking at how do you do that, and also then how do you start to predict longitudinally, you know, what will this patient look like in 5 or 10 years? What is the potential, you know, burden of illness? The same thing along those lines, when you're measuring outcomes, you can then bring it back to the physician, and you can start to drill down, and you can say, is it that I had a physician who maybe wasn't as good as I thought? Is it that I was at a place where I didn't get, you know, the greatest care? Or was it actually that it was a post-care episode? It was a nursing home or someplace else that I went to that actually contributed to that. So having support, and people like all of us really supporting the aggregation of data and being intelligent in our leadership about protecting PHI, but also making sure that we have the right avenues to start to connect that information is really important. And then embracing these models, and that's a big part of what we've done, where you've got both the clinical side connected to the financial, because if we don't look at both, it never really answers your question of how do I make a really good choice that's balanced about the care that I want to receive. So there's a lot of good things that are in the wings, and I think we can influence those from our positions in the industry about how do we secure data, how do we de-identify data so that we can start to make sense of it. Because data liquidity, at the end of the day, is really one of the big barriers to connected care. And we have, I think, the intelligence and the knowledge to really help move things like that forward and find those solutions. And some of those are technology solutions. We're working on technology solutions around how do you de-identify data but still keep time synchronization in it so that you can see dosage and, you know, some IP around that. Those are the kinds of things I think that will really facilitate, you know, connected care outcomes, people being comfortable. Companies and payers will probably never be comfortable with all their information, but it does work. So in Colorado, we've seen huge savings. They've seen about $40 or $50 million of savings through basically the rollout and the implementation of their all-payer claims database. I mean, it's phenomenal results. Just people being able to log on and see that an MRI cost me $1,100 here and it cost me $400 there, and being able to make that informed choice.
So I'm going to jump in for a second and talk a little bit from the outpatient management side, because I think you bring up a really important question of what is healthcare consumerism, and how do we, as consumers of healthcare, be our own advocates. And there's a lot of data out there, and I've been on the All Claims database, and it's hard to navigate, to be fair. It's hard to navigate as somebody who's in the business. So I think when we talk about healthcare consumerism, there's outpatient and there's inpatient. So that's sort of the first dichotomy. And you can measure inpatient a lot easier. How much was a hip replacement? And you can bundle it based on DRGs related to, is this orthopod better than that orthopod? And is this hospital better than that hospital? But it's much harder to do at the primary care level, to be fair, which is where we're all starting to interface, or a sports medicine clinic. And so this idea then of transparency, I think, is really important because, the MRI that you're having read at the standalone imaging study is probably read by the same radiology group, to be fair, that's also reading at, Intermountain, as an example. And so how do we then deal with quality and cost, and how do you, as the consumer, get reliable information to be able to say, okay, well, I think I'm going to hit my deductible this year, so I've got to stay within network so I can play the insurance game. Or I don't really even know the questions to ask to be able to be my own health advocate. So this idea of healthcare consumerism, I think we're really in our infancy of, and being able to navigate the system when there isn't a lot of transparency, I think is really challenging. And I think we are absolutely moving in that direction. I think that we as consumers are getting a lot more savvy because at the end of the day, it is our check that we're paying. And with the cost shifting with high deductible health plans to that patient for those high deductibles, $3,000, I've seen a $10,000 plan, that really you have to go and seek data. And then the other side is that the clinical team, right? Me as the provider, I need to know the prices also to know where to navigate and to send you. Because at the end of the day, if I say to you, well, just go get an MRI and you get to shop the market and wherever you want to go, and here's the prescription for getting this done wherever you can get it done at the cheapest cost. I can't tell you that 10 times out of 10, the patient says to me, well, where do you recommend? And if I don't have the data as the clinician advocating for my patient, then how do I ever even answer that question? And so really moving us to that next level of, okay, what does it look like across the system, and making it really easy for consumers to type in and say, where is the cheapest MRI, assuming quality is the same, all right? Or what are we rating quality on? And what are the metrics? And are they the right metrics that we're using? Is it time to getting into that MRI? Is it, a panel of 3 experts would agree that this MRI reading is the right reading, which at the end of the day I would argue is really what you want from a quality standpoint? Is it just cost? And I don't think we're actually answering those questions when it comes down to quality. And that's the Achilles heel, is because I don't think that you can make an informed decision to be your own health advocate if you don't even know what the data shows or what we're asking the right questions.
I think you bring up a really good point. There was a study that was published by Harvard not too long ago that basically directly links better outcomes with basically the closeness or the frequency of your connection to your primary care provider. So really being able to measure continuity of care as well as access to primary care are clearly, key components of how do you get to connected care, how do you get to better outcomes.
So we're talking about the patients and maybe their role or the healthcare consumerism. I'd like to pose this question to Diane and others. Let's start with Diane. How is your organization thinking about patient portals and patient communication?
Yeah, so we have had a patient portal for at least 8 years. And when we first started on this journey, it was more provider-centric. If a provider wanted to engage in a portal experience with, and have a way in a secure manner to share information or to allow individuals to ask questions, we allowed our providers to decide whether they wanted to engage. And that has dramatically shifted. And now we're at the point where, anyone that interacts with Intermountain will be invited and have an invitation to engage in the use of a portal so that they can have meaningful dialogue, meaningful results, and health information that again focuses on we want to have and foster a place where you can get reliable information about the care that you're seeking or the questions that you have. And, you know, we talked about just a few minutes ago, you know, are you getting better? What we haven't done from a nationwide perspective is spend enough time talking about end of life and making appropriate choices. And you really want, when you're making those series of decisions, do I have chemo, do I not have chemo, to really have a reliable source, a connection to a healthcare organization that where you can have that meaningful dialogue and connect with a primary care provider as you're making tough decisions. And so we have incredible subscription signups, for lack of a better term. You know, if you're in the pediatric space, we're in the high 90s in terms of when we invite them to participate electronically with us, they respond positively and say, yes, I want to do that. And if you're talking about the general population, we're in the mid to high 80s. That's quite incredible when nationally the numbers aren't that high. And that's the experience we've had at Intermountain Healthcare. And it really focuses on how easy is the technology to use as a consumer, and is there value when I'm interacting with the information inside of the portal. If you do those two things, people want it. And you have to shift it from only if my provider says it's okay to an expectation of the care that we deliver.
Thanks, Donna. Do you have anything to add?
Sure. So I think we also need to talk about populations. So when you're talking about an older population, so I'll use my mom as an example. My mom can barely figure out how to send me an email, let alone figure out how to get onto a portal. So I think that when you're talking about an older population, Medicare population, as much as I love portals. I love emailing my patients. I love sending them information. I love the technology. But my patients can't receive that technology depending on sort of the subpopulations that we're talking about. So I think the millennials, I think that it is an expectation for the millennials that we correspond with our patients in that mannerism. I think sort of the Medicare population, it is a huge challenge for them to interface with the patient portal. And then there is sort of a bandwidth in between of those sort of the rest of the population on whether or not they are tax savvy enough to be able to use it. How many people, we have a portal for all of our clinics, and you know, I practice primary care 1 day a week, and I routinely ask every single one of my patients, do you know your username or password? Because when we do this test for you today, I'm going to push that information to you. So how many of you have a patient portal connected with your health system? Okay, now leave your hand up if you know your patient password. Okay, so this generation is a generation that would say, yes, I know my username and password, and I can interface with you. And from my side of the table, from a clinical standpoint, I think it is critical to have multiple different venues on how I interface with you. Whether or not it's sending you an e-message saying, hey, you missed your appointment, what's going on, so that I can get you back in. Or here's your test results, everything looks great, I'll see you next year. Or hey, we seem to have a problem, look at the things in red, and I need you to schedule an appointment to see me so that I can follow up with you. So I think patient portals are important. I think it is one strategy in terms of patient communication, and I think depending on the population, it is a more effective or less effective strategy moving forward from there. But I think having that data, I think gets to that point of that electronic medical home, which I think we need to continue to move forward with. But here's the challenge that I would say that faces all of us in the room. So I move from one health system to another health system, and I want to still access that data that was in the old portal. It's not really old, it's still there. How do we create that cross-link to be able to suck that data into the new portal?
So Donna, thank you for that introduction.
We did not tee this up that way, for the record.
Because clearly HIE is the way that we need to do that. And we have been asked over and over again, you allow for disparate providers to come together and connect them so they can easily see aggregated data, but you don't allow the patient. And why not? And so this year we are sending out an RFP to allow patients and or their caregivers, because you're right, my mother's not going to jump on the portal, but she will, by gosh, I will on her behalf. So that they have that look into that aggregated data. They have control over that aggregated data, and when they want to move to another insurance, or they'd never leave you, but to another primary care, they can take that data and move it to that primary care. So clearly, that is another opportunity for us, another connection for us, is to connect those patient portals and that data so that the patient has aggregated data as well.
Which is really good because to your population question, you know, my mom invited me to have a Facebook account because she wanted to be my friend. I'd sworn never to be a Facebook consumer, but here is my 72-year-old mother connecting with me. And I think we have to be careful that we don't categorize people
That's
by
fair.
population, but instead, to your point, how do they want to engage with us in their health care? It may be through a portal, it may be through a one-on-one interaction, it may be through a trusted friend. And how do we provide information and the tools no matter how they want to connect? And again, technology, it's not about technology. Although my job is all about technology, it really is about how do we enable the best care for that individual, given what they're experiencing, and how do we enable technology, HIE, tools for the primary care physician, tools for institutional organizations like Intermountain Healthcare or other integrated healthcare delivery networks, or the mom and pop single office for a provider. How do we enable this in a manner that individuals can engage with us in improving their health?
Thanks. Let's take a question from the audience.
I'd like my health information to be brought in from all different sources. And I know that siloed information in different systems, that's kind of the biggest challenge for us. So I'm excited, with the effort that UCAN is doing with their patient portal investigation this year. But ultimately, it comes down to who am I and how are they tracking who I am. So I'm just wondering what kind of political forces will need to come into play to have a nationwide unified master patient index. So I'm not in the system 4 times, and is that me or is that not me? I'm just wondering what you ladies consider the likelihood of that happening kind of in the political climate.
When do we want the government to know everything about our health?
I want to know everything about my health, so I don't care what the government does with it, but I think patients are going to soon demand that I'm one person and all my information is available, and you can't do that without a unified master patient index, I don't think. Question, ladies, what's your opinion on that?
Well, and I have to agree with you, and I agree with the gentleman that spoke up. That is the reason why we don't have a patient ID, because there was so much fear and paranoia that once you have that ID, that people are going to know and be able to easily gather data. And so the government has shied away from that, although I think they're starting to realize the millions, maybe even billions of dollars that are being wasted, maybe not wasted, but used for master patient ID software. So we all have an MPI software. Every healthcare delivery system has to buy the same one. And it's because they need to know that this Teresa Rivera from Dr. Levine is the same TL Rivera that went to Intermountain, is the same T Rivera that went to St. Mark's. And maybe they have an old address, and how do they do all that linkage? Linkage, it really is linkage. And so it really is an issue today. And one of the things that we have to be so careful with in the HIE, and I believe the health systems do the same thing, is to be very careful and almost err on the other side, where we will not link you if there's a possibility, that a remote possibility, it's a different person. Our motto is to do no harm. And so that means that my data might sit in two silos for a little bit until we can figure out those are the same people. And I will tell you, I know this from Intermountain and University of Utah and HCA, as well as all the other health systems. They spend a lot of people and have a lot of resources that work every day to try to link those people together, the correct people together, and not link the correct people. In fact, I chuckle at a study we were doing with Intermountain where they had like 1,300, I think, pairs of twins that should never be merged, but they had all the data that would want you to merge them. And so it is so careful, you have to be so careful not to overlap those two clinical profiles, because you could really harm the patient. It is an issue, although I heard that because of the millions being spent on it, that there is some discussion going on at the feds.
So I'd like to ask a question to JaeLynn and Donna. In a connected health model, how can we measure the care that we're delivering through connected health measures?
Want me to go first? Sort of a loaded question. Because there are standards that are out there right now called HEDIS Measures, which I think Teresa sort of mentioned, which check a certain box, but don't necessarily translate to health outcomes. And I think kind of the step that we need to take before the HEDIS measure step is what is the desired outcome that we want for X? And if it's diabetes, then it's not just doing the A1C, right? Because anyone can do an A1C, but it is getting your A1C under control so that you have improved long-term health. So I'm not sure if we're actually asking the right questions with the standards that we currently have in place. And I would agree that we have a lot of process. Did you do this? Did you lift the patient's head of the bed? Did you, check a foot exam? But did it say, did you see the ulcer on their foot, and did you get them to wound care? So, because from my side of the table, that's what's going to impact on whether or not they're getting their foot amputated or not whether or not I just check their foot. Now, you could make the assumption that, well, if I'm doing this, then that will happen. But I'm not sure if you can correlate one with the other. So I think from my side of the table is, I think we need to have a better definition of what the definitions are to really correlate with improved health outcomes. And once we get to that stage, then I think we need to track those, because from the clinical community standpoint, so I'm going to put on my sort of advocating for other physicians, is that I think the big pushback that we see in society, in medicine, is that I don't see the merit of having to check off those boxes because it doesn't do anything in terms of improving my patient's health. And until I buy in terms of doing that, you're going to get a lot of sort of controversy or sort of pushback from the medical community, because I don't see how it helps my patient.
So I would just say that I completely agree with what Donna said. So at 3M, we were involved in the original implementation of DRGs, diagnosis-related groups, which is really just what resource utilization is fair and adequate for a good outcome. And that was probably one of the most successful, if you want to think about healthcare cost management. I think it actually lowered GDP by like 1.5% back in the 80s when it was implemented. So we continue work on that, and we have worked with a majority of the states, and there are a lot of really innovative things happening with the states. And why is it happening at the state level and not the federal level? Well, because states have to work within a budget. So they can't run in the red, they have to work in a budget, and they need to take care of their populations with good quality with the money that they have. And so they've been much more innovative in adopting some of these methodologies. So the way that we look at it is the first step is you take your entire patient population, not just your Medicare, but everyone, and you risk adjust it for severity of illness and risk of mortality, and that's kind of your baseline. So from there, then you can start to look at what methodologies should I do. We look at it from a rate base. So for example, potentially preventable complications. We know that there will always be complications, that even the best physician, the best healthcare system, it would be completely unreasonable to think that you would never ever have a complication when we're talking about all the different comorbidities and complexities of people. Same thing with readmissions. We know that occasionally there are going to be very legitimate readmissions that are going to come back. So the question is, we start to look at how to pay for care or how to measure a physician is, are you out of bounds on the rate? So is your rate higher than what the expected rate would be for this service? If it is, then that's when there's a reason to dive into that to understand why, and we kind of talked about all the factors that could actually contribute to that. It may have nothing to do with your actual physician or even the actual place of care. But that's really how we need to start looking at it. And I think it allows us to do a couple of things. One, the clinical models are here. They're built on clinical models that are attached to the financial outcomes. So it is your clinicians who help, through panels, build what should be included, what is an outcome, why does that matter. The other thing is, I think it goes back to where we started with what we want when we talk about connected care. I want to trust Donna, just like she said, to tell me what to do. So I want to leave the physician or my caregiver or my clinician some latitude in there who knows me, who knows my family. Maybe they know that every 15 seconds, we go out in the sun and we get a rash. So when they see me and I have a rash, they're not particularly concerned because they know that it means nothing for me. But maybe that's a really big sign for somebody else. That caregiver who knows what's out of bounds for me, I want them to be able to adjust those process measures. I think the other thing is we are creating inordinate amounts of cost. There are hundreds and hundreds of quality measures, as you all know, that we are all responsible for basically outputting out of systems that don't output them very well, measuring, putting those inputs into systems. And we have to ask ourselves, does that really take us where we want to go? A lot of those are these kind of in-between metrics that I would call process measures that may or may not actually impact your care. We're saying, let that nurse, let that physician, let those people who are the experts, who can see your face, who are doing that personalized care, really decide on those in-between pieces of what's the best care pathway for you. And let's focus on the payment and get the incentive. Because when we get the incentive aligned with the right outcome, I think that's where we get to where we want to go. Otherwise, I think we'll be kind of placing bets and spending lots of money in lots of places where we don't really get, it's kind of like playing Powerball. You put the money down, but you're probably not going to get anything back.
So I want to just add one more thing, and that is, when we talk about outcomes data, we're making the assumption that the patient is fully compliant in the care process. And so I just want to put that out there, that my incentive is based on whether or not your A1C now is at 7. And if you choose to go out and eat those ding-dongs, man, I can't stop you. I don't have that taser to say, don't eat that. So I say that a little tongue-in-cheek, but I think there is two parts to this relationship, and half of it, to be fair, or maybe 90% of it is actually on the patient side. And so we need to have this conversation in the medical community to be able to say, okay, do you want to be compliant as a diabetic? Because, if you don't want to, I'm kind of done here. I'll check off the box that says patient desires not to be compliant HEDIS measure, because that doesn't exist in the infrastructure today. And I can talk until I'm blue in the face, but I can't change your behavior. Only you can change your behavior. But we can also use really cool health information and technology tools like smartphones and Fitbits and things like that for me to be able to turn around that tablet and show you, if you just walk these many more steps or you just stop smoking, this is how many more years of your life. And that's a very powerful tool for me to motivate you to do the hard work that you need to do. And it has nothing to do with dollars and cents. It has to do with life. And that's where it sort of comes back to. But I thought I would sort of round out that conversation by adding the other half of that relationship.
Great.
I would also add that one of the neat evolutions of our world is the fact that we moved to digitized records. I mean, how many years, I mean, I can still remember the paper charts behind my doc's office where they had the whole wall of paper charts. There was no way we could do any of this data sharing or population management until we digitized that process. We are there. This is an exciting time to be in informatics because all this data now is there, and it's an opportunity really for us to focus and figure out what are the clinical measures that are going to make sense and how do we get this data to our doctors. It's an exciting time to be in IT.
I'd like to give the audience another chance to ask a question before my final question. Anybody have any comments?
I was just curious as to the thought to complete the life cycle. What are the thoughts as far as incorporating the person's input into their care process with these disorders?
I think that's the key to what Donna said, and that is, how am I doing, and how can I contribute by saying, how much, if I have congestive heart failure, how much do I weigh, and if I'm diabetic, what about those ding-dongs, and my desire to be compliant. That's a challenge but it's where we have to go. And the reason it's a challenge is because where do you insert it in the record and how do you show it, and how reliable, there's a trust factor there from a care delivery model, and how do you differentiate the data from patient or family contributed to a lab value for a blood sugar. Home versus something collected, and we've got to figure that out. If we don't do that, we'll never get where we need to go to have the meaningful dialogues with the consumers of health and make a difference in their lives. And so we're beginning that journey to begin figuring out how to allow someone from home to contribute to their record as they come in for a procedure or as they're taking care of a chronic condition. So we've got to round that out. I don't think anyone's solved that in an elegant way yet.
And I would absolutely echo that. And also to say that it has to be in different languages. It has to be able to be really user easy on many different levels, because there's a whole spectrum of how people are their own advocates. And there's a lot of information that's out there now called this wonderful thing called the internet. And some of it is really good data and some of it isn't. I say to my sister, oh, Glamour magazine, that reputable medical journal. So when she asks me questions, so some data isn't as good as other data, not to disparage Glamour in any way. I subscribe. But the idea is, is all data the same? How is it weighted? How do I want that data to be entered? How do I modify that data? And is that data available in different languages? And then how do I get it translated so that I can understand it as the clinician as part of that? But I think this whole idea of healthcare consumerism and healthcare advocacy, sort of going back to the person who was talking about earlier about their mom breaking their hip, is that we really are moving into the realm of healthcare transformation, that we have to be our own best advocates. And how do we get that information? Number one, how motivated are we to seek data? And traditionally, healthcare has been a pretty disease model-driven mechanism of care, right? You come see me when you're sick. You don't come see me when you're well. This whole idea of preventive care, man, we're still young as this even being reimbursed in healthcare from a claim standpoint. So again, shifting from a society to disease care to well care, I think is part of that conversation also.
And I would add, in defense of Donna, she said it, there's a lot of information now. How do we compensate the primary care to review all this information? We have CCDs that could be 300 pages long.
Yeah.
Now, how are they going to spend the time when they're at this fee for service where they're only paid so much for a quick visit? It is a transformation of the way we deliver and the way we pay for healthcare that needs to happen.
Yeah, absolutely.
So let's conclude with each of you taking an opportunity to paint a picture of where you see connected care in 5 years. Let's start with JaeLynn on this one.
So I think a good way maybe to paint the picture of where connected care will be is to share an experience from one of our customers. So Children's Healthcare in Dallas is one of our customers, and they have been working on population health and reaching out. And they created a partnership with the local school system in an underprivileged area, and they invested in telehealth equipment, basically scopes and other things, and they have made it possible so that when a child gets sick, they can go to the nurse in the hospital. The nurse coordinates with the local hospital there with the Children's Medical Center of Dallas, and they get diagnosed, they get treated, they have any prescriptions or meds that they need, so that by the time that the parent arrives to pick that child up from school, that child has basically already has the medications and has had basically the diagnosis, and they're ready to take home and kind of put down to rest, which is a huge thing in this particular area, because this is a place where parents who are working, they don't have maybe the flexibility that we have, like leaving to take a child to a doctor or to school could actually mean potential job loss or other hardships for their families. So it's really a combination of bringing together the community, the hospital, as well as technology, and it's having a huge impact on lives, and it's happening now. So the future is here already. We can do this, it's happening today. It's about our will and maybe just our creativity to kind of start some of the things to make them happen.
I see, of course, more connections amongst all the data providers. We focused with the meaningful use legislation on primary care, hospital. So we left out the emergency medical staff, poison control center, long-term care. And I have 2 friends that both lost their mothers, because the data wasn't transferred from the acute hospital to the nursing home. Medication was under and overprescribed in the nursing home. That is an error that shouldn't happen, not now that we've moved to the digitized age. So not only bringing in the primary care that we have, but now we've brought in all of those others that are involved in the care continuum. The care team is identified. Patients are involved. They know who their care team is, because many times a caregiver of that person doesn't even know who the care team is because the mother has gone wherever. So having that all together, medication reconciled, we really have data following the patient where it needs to be for good quality care.
So in 5 years, I see us from a provider perspective engaging with the patients in an entirely different manner, where how patients interact with us is convenient to them and their schedule and their time to engage in a healthcare conversation. If you're a busy working woman like me, it's not between 8 and 5. And my ability to say I want to engage with my provider and take some time off and schedule an appointment will look dramatically different. I'll be able to do that. But we'll also manage the populations and patients' conditions outside of the bricks and mortars of hospitals and clinics in a different way, so that we're focused on having those conversations about what does health mean to you, not just when you're sick or seeking to interact with me. And I think that changes the world of a provider in a dramatic way, and it changes the world of the consumer of healthcare in a dramatic way. And it makes me more accountable and more responsible. We talk about shared accountability, but without the patient in the middle of that conversation, we will never achieve the goals that we need. But technology, I agree, technology is here, and it's just going to take our vision and our application of the tools to enable really what we're trying to do in engaging people in conversations about their health at the point of time that matters to them, and in a way that doesn't drive our doctors insane.
So I'll be a little bit more philosophical and say that I don't know if we can have the conversation about what healthcare looks like without really undertaking payment reform on a national level. Because until we get to that point of having that serious conversation nationally as to what is an entitlement, what isn't, what care should be covered, what isn't, and take it out of the political arena, right? It shouldn't be based on who's president, that we really can't predict what that future looks like, because we still live in this fee-for-service world that I look at all of you as the virtual ATM machine for me. And until we make that transition and kind of stop being schizophrenic as a society as to how we're going to provide payment and what payments we are paying for, then we can really look at what the future of healthcare looks like. Because I would much rather sit in my PJs in my house and do telemedicine with you if you don't need to come and see me. And I absolutely agree that it shouldn't be 9 to 5 because we don't live in a 9 to 5 society anymore. And so how do we leverage this wonderful world of technology that we have to do things in a much different way that the traditional healthcare system focuses on, both from a disease standpoint as well as a you come to me, I don't go to you approach of healthcare. But we can't have that conversation until we decide on how that payment looks to be fair. And so what I would say is, it's probably above all the pay grades of all of us in this room, but I think that it needs to come from us. On what we want healthcare to look like in the future. Should it be with employers to provide healthcare for their employees? Should it be individually? Should we all be on the exchange? Should it be, a single party payer? I don't know what that looks like, but I think we need to have that conversation nationally before we can get to the future.
I'd like to thank the panel today for this important